Hello. So I'm glad I'm on the right one. I tried the other and it didn't work.
How are you?
And wow.
Good, good. Yeah, I'm hoping. I thought people would be on. Do you think we're on the right one?
Well, that's what I was wondering. I looked at the one from the flyer and it was invalid.
It
Um,
was? Okay.
and so
Okay.
I think this is the only one that does work. So maybe we're just the early ones.
Okay. Yay. Good for us.
Yes.
Sarah, I know Sarah. Hey, Sarah.
Hi, sorry, just looking over my notes one last time.
No, you're good. I was doing.
I didn't even practice, so I'm like, it better be 7 minutes or less.
Yeah, we'll get through it one way or another. I keep telling myself it's 7 minutes of my life, so I can do anything for 7 minutes.
Amen.
Hey, Sarah.
Hi, Megan.
How are you?
Good, and you? You look lovely.
Oh, I was thinking the same thing. You look beautiful.
Oh gosh, thanks.
Yeah. How is life? It's been too long since I've seen you.
I know, I know. I'm good. You?
Yeah, good. Yeah. Except for that, my daughter, who is 10, is already dealing with boy stuff. And I'm like, ah,
Oh my goodness.
not ready.
Junior high threw me for a trip. That is
I don't
crazy.
even know. Yeah. I'm like, can I just send you away? All girls school. I mean, I don't know. Maybe. I mean, I don't know which way she. Like if she's. Yeah, it's hard to know what my kids' preferences are yet. So maybe that would have its own set of, have challenges too. So anyway.
Sarah, how's your stuff coming along?
It's better now that I expanded the eligibility criteria.
Oh,
I've
good.
like been hitting it really hard, like everybody I know. I need two more LGBTQ couples to take my survey, and then I'm done.
That's amazing.
That is really huge, Sarah.
So yeah, getting there.
Congratulations.
Yeah, thanks. I like totally shocked to leave when I told her last week. I had like 2 weeks ago when we met, I had 3 couples who had completed the surveys, the LGBTQ couples. And then last week when we met, I was like, I have 17. She was like, what?
That's amazing.
So,
Good.
very happy to almost be done collecting data.
Yay. I'm so happy for you. I'm so jealous.
Yeah, tell me what you're doing.
My recruitment has gotten much better. I have 18 done and 2 more in line for surveys, or for interviews, which is great. My interview piece though, or not my interview, my survey piece is continuing. Thankfully, I've been collecting it with my participants that are doing interviews, but I don't think I'm going to get a full powered sample like I wanted. So we'll see.
I'm sorry, that sounds so stressful.
I'm so happy for you. That's so great.
Hello, everyone.
I figured we could give people a couple minutes to trickle in before getting started. I apologize for my dog who is making a lot of noise today, so I will try to keep her not involved in everybody's talks.
Hi, all.
All right, well, we can just start getting started with introductions and people will trickle in as they may. I believe all the presenters are here. Yeah, I think almost everybody, if not everybody. Okay. Thank you for coming today. We are all very excited about having the opportunity to have some of the more fresh people give some presentations and see where CFAHR is at right now. So the way that this is going to work is everyone is going to get 7 minutes and then we will do 3 minutes for questions. I will be keeping time on my phone as effectively as I possibly can. And I will do the little raise your hand deal when you have 2 minutes left for your talk. Hopefully that it will call to your attention. I've noticed that trying to say something in chat is hard to pay attention to when you're sharing your screen. So hopefully raising hand will be better. So might as well just get started so we don't waste a bunch of time chatting. So we've got excellent representation here. We're going to start off with Amber Thompson, who is from the sociology department. So I believe you should be able to share your screen if you want to just take it away.
Okay, Amber, can you hear me? It's Austin. So I have everybody's all put together all in one giant presentation. And right as I hit play from the beginning, Amber, your time will start because I know you have timing. So let me go ahead and share my screen.
Perfect.
Can everybody see that? Awesome. Okay, Amber, you ready?
I'm ready. So as Austin said, I'm Amber Thompson. I'm a doctoral student in sociology working with Professor Rebecca Utz. My presentation is called Porous Boundaries, and I'm focusing on the relationship between families and healthcare workers during a patient's end of life. So traditional boundary work with regards to healthcare settings focuses on the patient-physician relationship. In that situation, the physician is called to navigate a variety of different identities. And I'm just going to throw out there, Austin, I don't think that the timing is working. There we go. So the physician is called to navigate a variety of identities. And this includes a socialized professional hero, but also a caring human. So the physician is pushed and pulled in between these different identities, with the hero being more detached, professional, always knowledgeable, and able to navigate multiple issues and patients with the purpose of healing and curing. So this is in balance with, and sometimes tension with, this human identity, right? Where they're expected to be caring and empathetic, but also to be a team player in order to achieve what we call patient and family-centered care. So what we found in previous work is negotiating these boundaries at the end of life becomes very blurred for many healthcare workers. Sorry, I want to switch my screen for that next one. There we go. So it becomes blurred for many healthcare workers. In recent work that we've done, which we have referenced down here below, what we found is that healthcare workers aren't successfully managing these boundaries and these barriers very well. It's resulting in negative mental and physical health, which includes burnout, compassion fatigue, increased stress, depression, to name just a few of these. So what we found is that negotiating and balancing these roles and boundaries at the end of life is unique because healthcare workers aren't able to always achieve that professional hero identity. You can't cure and save every life, but they're also lacking sufficient training and support in order to be able to engage in that human identity without suffering some of these negative consequences. So what we also saw in this particular study was that when we're at the end of life, the family is a very important factor when they're negotiating the balance of boundaries and roles. So when we think about the boundaries that a healthcare worker has with a patient, and Austin, if we can go to that next slide, there we go. If we think about those boundaries that a healthcare worker has with a patient, once the family's involved and once we're in the context of death and dying, we start to ask questions. Who's grieving? What grief expressions are appropriate and for who? Who's supposed to provide support for the patient? And if you're in a relational team-based approach, how far does that support extend? Is the healthcare worker supporting the family? Does the family reciprocate and support the healthcare worker? So how involved or detached is a healthcare worker when death and dying is in the realm of the family? So in this particular study, we're exploring how those traditional boundaries that are set by healthcare workers are often violated or they need to be crossed when we're dealing with families during patients' end of life. So similar to our previous work, we're using a digital ethnography. It's coming from an online public forum, and it's where healthcare workers are going so that they can offer or receive support, they can process, but they can also try to connect with others who might identify with the stress of coping with patients' death and dying. We collected data for a year. We have 837 total posts, but for this project, we're focusing on the 242 relevant posts that are associated with how families are involved in and are affecting these boundaries and roles at the end of life. So far, we've done our general inductive analysis, and what we think we're seeing is these 4 emerging themes. This first theme is all about, should I or shouldn't I cross these boundaries? And it's represented by these different quotes, these contrasting. The first being, I should. We have so many clinical skills and tools at our hands, but some days we just hug people and hold hands, and that's okay too. Now that's contrasted with someone who's more in the camp of I shouldn't or I can't. When I came to work again, I was told you were dying. I had reassured you and your family. I wanted to visit you and see your family, but no matter how hard I tried, I couldn't bring myself to do it. So our second theme here is all about whose role is it to do the supporting? So frequently the support of the patient is in the realm of the family, but when the family is unavailable, frequently that healthcare worker will cross that boundary and will fill that role, but might interpret that absence in a negative way. So for this quote, this reminds me of the strongest memory from med school, spending a couple of hours every day chatting, playing, and reading with a 3-year-old with leukemia. We didn't see her family the entire rotation. So our third theme here, this is all about the contrast that what might become routine or expected in healthcare work is traumatic. It's life-altering for families. Do you ever do that thing when a patient you're caring for dies and it doesn't really affect you until you see how it affects their families or the nurses or learners? And the weight of that patient's life hits you suddenly and you feel like a monster for not feeling it earlier. This really highlights that tension between that detached professionalism, but also that empathetic caring, which is needed at the end of life. So our fourth theme here is all about relationships and relatability. Very often we're seeing that those boundaries and roles depend on whether or not the healthcare worker identifies with that patient, with that case, maybe with that situation. Sometimes we see patients' kids' cases that hit too close to home, and it's hard to be objective, detached enough, not detached too much. So what these four themes are really trying to tell us is that boundaries are important, but they are being crossed, and the navigation of them in real world is very different than in theory or in the classroom. So in terms of boundary work that we see in research, we anticipate that our findings are going to support that patient end of life, that process of death and dying, it's different than most other healthcare encounters, and it might require different boundaries, different expectations, training and support. But also in particular that these boundaries and conversations about boundaries, they need to be expanded beyond that traditional dyad of patient-physician to patient-physician and family, because they're such an integral part of this process. But then also, these professional boundary conversations, especially at end of life, need to apply to all healthcare workers, not just physicians, because they're all discussing these similar negotiations when they're dealing with the families of their dying patients. So overall, altogether, this study is telling us something about why and how that patient and family-centered care might suffer at the end of life. And that may be due to that role ambiguity that's currently experienced, but also because there's a need to cross those professional boundaries in order to better support that patient and those families during that death and dying process at the end of life. Thank you.
All right, so we have 3 minutes for questions. If anybody has any.
Amber, that was a really interesting talk. Nice to see you again. And I just wonder if you could speak to boundaries when the healthcare provider comes into the home and how you think that might change versus in the hospital or in the clinic.
So that's a really hard one. From what we've seen, when I interpret that, I see it as more of maybe the palliative or the hospice care that's going to be going into the home. And we've seen that there's some negative effects there as well, but they get a lot more training when it comes to that end of life. So that might actually just be one of those next steps for our research, is to see maybe can we find out more information about how that boundary work and those roles may differ between preventative medicine versus palliative or hospice care medicine. I don't know yet because we're kind of at the beginning of exploring this area and how the family is, but I would assume that there would definitely be some boundary crossing. What we don't know is how much that crossing is going to turn into a boundary violation. And that would be kind of the key.
Amber, that was really a good presentation, and I enjoyed your summary. I may have missed it, but you says it's a digital ethnography.
Mm-hmm.
I don't know what exactly the source of the, are these things people wrote on a website, or are they, I'm not sure where you sampled the digital content.
Yeah, it's specifically an online forum that has set out for its purpose, its calling is to give providers a safe space to go and to discuss their issues with death and dying and their processing of death and dying. But it is an online forum, so it is open to the public. We did make sure to get permission from the site administrator, but since we didn't participate, we didn't engage specifically with the individuals. We simply let everything come out naturally and then just collected the posts as we saw them.
Okay.
All right, that was perfect timing. I think we are ready to move on. So Devin, you go ahead and take it away.
Awesome, thank you. Yeah, I have some overlap too, like with Amber's presentation, which I really like. So yeah, I'm happy to present. And this is a recently submitted, we're going through, we just finished our first revision for this paper. And I have two co-authors, Matt Huey and Dr. Glenn Kreiner, and we're all in the organizational behavior department. And so we looked at, we can go to the next slide. Yeah, so this is a study that I started last summer, kind of after COVID started, and I was like kind of unsure what to do. We were worried about like online samples, and I had never done any qualitative research, and just thought, the pandemic offers this really interesting environment. And so I started the project by myself, and later Dr. Kreiner, who's my advisor now, joined the University of Utah in August, and that was great. But initially, I thought that we might, with all the healthcare hero attention, I kind of naively thought that maybe that would help kind of engage and motivate the healthcare workers. And I had been a nursing home administrator and a healthcare recruiter for 6 years, and so I tried to think, if I was still in there, what would this be like? And there was a lot of attention, and it was still kind of early on. And we can go to the next slide. But so we ended up interviewing 93 healthcare workers. There were 67 of them had dealt with active COVID cases, 68 frontline workers, and most of our interviewees were married or cohabitating, and over half had children. And 87 of them were from the United States and 6 from South America. So basically, like, I included this slide just to say, like, most of my predictions were really bad and wrong. So we kind of right away, or I right away realized, like, wow, like just in the interviews, that the experience for most of my interviewees was not very positive. And there were like some, sense of calling and interesting thoughts there, but the overwhelming story, and this was grounded theory, really was like, wow, there's a lot coming at these healthcare workers from a lot of different angles. So we can go to the next slide. So our initial findings is there were some examples of increased pride, but we started to see a lot of them on their own talk about burnout. And like a lot of the discussion was about how there were so many angles and so much happening that was just like annoying. Like, you turn on the news and they're talking about it. You talk to your neighbors that they want to talk about COVID. And so they just didn't have that sense of rest. And so we started to look at this with a boundary theory lens, and just started to kind of see how the boundary violations and how they manage those boundaries. So what we found was that healthcare workers, couldn't get away. So this nurse talked about the emotional exhaustion and said, I had nothing else to give to anyone else emotionally. I hated watching TV because it was all about COVID and trying to portray how rough it is for nurses and doctors. And I just didn't have any unwind time away from COVID because it was everywhere and the only thing anyone talked about. So this is some of our sample interviews, and I'll maybe skip through this. I realized that I offered too many slides. So if we go to the next slide, we saw this trend of boundary violations causing burnout. So this nurse said the staff are dropping like flies because they're so burned out, and said this was the first time in his 6 years of working in healthcare that he had not been able to leave work at work. And so we categorize these boundary violations as physical, temporal, and knowledge. And we started to see kind of how there were like, so my co-author, Dr. Glenn Kreiner, had seen this with Episcopal priests in 2009, but we saw a new violation that he hadn't seen before of knowledge violations. In this case, healthcare workers had to deal with ignorant opinions and questions that were insulting and revealed how alone they were in their experience. So this nurse said, people called us sheep for wanting or taking vaccines. We also highlighted physical boundary violations. So how they would, and in this case, physical boundary work, where they would kind of separate work and non-work. In this case, like, you know, going into the garage and changing, and a lot of different rituals people had. Like one person would take a ladder up to their bedroom before they saw their kids. And this is an example of a segmenting boundary work. So this one said, this physician assistant said, I will work extra shifts, but during COVID, I was like, no, I can't handle more than 3. And then I would have 4 days off to relax. And I would just literally sleep and do nothing on the 4 days. It was a good way for me to prevent burning out. Looks like I have about 1 minute left. So let's go to the, well, actually, yeah, sorry about that. So this physician assistant talked about writing a weekly email to friends and family who were maybe from like a more conservative area, didn't necessarily believe that COVID was real. And so we called this code advocating with facts and science about the pandemic. And so, sorry, now we can go to the next slide. And so these are our contributions. We utilized a boundary theory lens to interpret the effects of the pandemic on healthcare worker burnout and categorize the boundary violations and subsequent boundary work tactics that were used in response. And so it was a really interesting study for us, and happy to share any other thoughts if anyone wants to, you know, connect about it offline or anything.
Awesome, thank you. Any questions?
Devin, that was really interesting. I had a quick question. So how did you find your participants for the interviews?
Yeah, good question. So we used convenient sampling, especially in the beginning. So I worked in nursing homes as an administrator, and then I was a healthcare recruiter for a few years. And so I kind of had a big network. Like most of my recruiting was done in like New York City and Chicago and some areas that like kind of were especially hit by the pandemic early. So I used some of those contacts, and then also some networking like at the Academy of Management, where I could get people from like Brazil or other places too. So
Great, thanks.
I just want to comment, it's very interesting work, and over 90 is, I don't remember the exact number, is a huge sample for in-depth qualitative interviews. That's just an amazing amount of work.
yeah, thanks. My advisor was like, kept kind of saying, stop interviewing, please. It was my first qualitative project, and so I think I naively just kept going.
All right. Well, if we don't have any more questions, we do have some time. So if anybody has any burning questions, go for it. But I think we're ready to move on. All right. Next up, we have Mary Jane Campbell from the psychology department.
Awesome. Thank you, Jenna. Yes, so like she mentioned, my name's Mary Jane. I'm a clinical psychology graduate student in the Department of Psychology. And today I'm going to be talking about adapting an mHealth intervention for emerging adults with type 1 diabetes. So for a little bit of background, emerging adulthood, so typically defined as the ages 18 to 25, is known as a high risk time for type 1 diabetes. Part of this is because these individuals are still developing self-regulation skills. Parent involvement typically declines during this time. They're developing new relationships at work or at school, and sometimes these can be unhelpful in managing their type 1 diabetes. So this is a really unique opportunity to optimize social networks during this age group. We know from some of our previous work that having others involved in supporting type 1 diabetes, such as parental involvement during adolescence, can be really helpful, but we know less about this in emerging adulthood. And so if you go to the next, so we had done some interviews in some of our previous work where emerging adults sort of recognized that they could use some support in this area, especially around asking for support and getting the support they need. So some emerging adults said, my friends would change their schedule if I would express my needs better, and telling others when it's a struggle rather than just dealing it with myself might make it easier. So they kind of recognize this need for a bit of optimization in their social networks. And so FAMS is an existing mHealth intervention for adults with type 2 diabetes. And this included components such as phone coaching, where individuals would meet with a coach over the phone and set goals related to their diabetes, talk about helpful and unhelpful behaviors from others, and have a little coaching on assertive communication to help express their needs and ask for help. It also included text messages to facilitate the goals that they set during phone coaching, and text messages to support a support person that was nominated to help facilitate conversation and providing support to the adult with type 2 diabetes. And so we were looking to adapt this for emerging adults with type 1 diabetes, and we weren't sure about a couple of things how to adapt this. So one was whether emerging adults would invite a support person at all. With the SMART goals that were typically included in the previous, in the type 2 intervention, and the ones we came up with too broad for type 1 diabetes, and what would they think about the text content that we would develop this? And so if you go to the next slide, we engaged a stakeholder advisory board as part of this process. And so this included 10 emerging adults who had previously participated in a study of ours. And we tried to get a sense from them, get their input about what this intervention might look like. And so we asked them to participate in a phone interview where we asked them about the types of goals that they would set for type 1 diabetes, what kinds of texts would be helpful for meeting that goal, and information about whether they would invite a support person and who that person might be. And we also sent to them some sample text messages via RedCap and asked them to try to tear them apart and tell us what they liked and didn't like about the text messages that we were thinking of including in this intervention. And so the initial feedback from the stakeholders went very well. So all of the emerging adults that we invited to be as part of the stakeholder advisory board said that yes, they would invite a support person, and 60% of those said they would invite a romantic partner specifically. We were curious about what their goals might be, and so common goals were keeping blood glucose in range and making diet-related changes. They told us that they really didn't like the texts that they felt were controlling or telling them what to do. They preferred the positive and encouraging texts, and they mentioned that they wanted more media content or CGM content for those that were on continuous glucose monitors, and also advice on how to start conversations with family members. So it was kind of what we were expecting, but it was nice to hear their feedback before we started the pilot of this. And so we just finished, we just wrapped up a 3-month pilot of FAMS T1D, and we had 30 emerging adults participate with a support person if they desired. And the preliminary findings were encouraging. So 21 of those 30 emerging adults did invite a support person to participate. 38% invited a parent, 52% invited a romantic partner. And the majority of those support people mentioned that the text messages did increase their ability to be supportive, and half of them said that those text messages encouraged them to talk more with the person with diabetes. And there was high engagement with phone coaching. So 88% of the phone coaching sessions were completed, which is pretty impressive with this emerging adult population, especially during COVID. And most of them said that these related to positive interactions with their support persons. And most said that the text messages helped them stay on track and facilitated the goals that they were working towards. So these findings were pretty encouraging to us that this adapted intervention went well. And so that's all I have. I'd like to thank all of the participants who participated in this intervention. And here's our funding information for the pilot.
Awesome. Thank you, Mary Jane. We have extra minutes for questions this time. So have at it, everybody.
Mary Jane, thanks so much for your presentation. I'm wondering, when you were working with the emerging adults, were the findings self-reported that they said that they stayed on track, or were you also tracking any like A1C levels or their blood glucose monitors?
Yeah, that's a good question. Most of the findings that I presented here were based on their own self-report that they felt like they helped them. But we do have data from A1C kits that we sent to them and some other things that we haven't quite analyzed yet. These are just the preliminary findings. But yes, so this was mostly their self-report.
So you said these were people that had participated in a previous study. Could you just say a little more about sampling and who they are?
Yes, absolutely. So the individuals, the 10 emerging adults that participated in a stakeholder advisory group, so before we did the pilot, were individuals that had participated in our previous studies that had agreed to be contacted in the future for future studies. And so they were the ones that gave us their perspectives on the phone coaching and the text messages and sort of whether they would like the intervention. But the 30 emerging adults that participated in the pilot were recruited separately from that. So they were new individuals.
And they're recruited how?
They were recruited here in Utah from various, and in California from various endocrinology clinics that we have here.
From clinic-based recruiting, basically.
Yeah, well, we did it a little bit differently with COVID. We were not inside the clinics
Right.
like usual. So there was more of online recruitment and follow-up phone calls to do consent and things like that.
That's sampled from clinic records.
Right.
Yeah, okay.
All right, if nobody else has any questions, Pascal, I don't know if Pascal is here, but he taught me to wait 15 seconds. So if you're sitting there thinking, why is Jenna waiting so long? You can blame Pascal. All right, so if we don't
Yes, I am here, so.
I thought I saw you. Okay, so we can move on. Next, we have Sarah Bybee from nursing.
Thank you. So I'd like you to imagine a world where instead of experiencing distress, depression, and anxiety, cancer patients and their partner caregivers can experience positive psychological changes and even develop more meaningful relationships with one another. Does it maybe sound too good to be true? Prior research indicates that this can and does happen for some couples facing cancer. My research investigates post-traumatic growth among sexual and gender minority and non-sexual and gender minority couples facing cancer using a mixed methods design. Cancer incidence is increasing in the United States, and as more adults get diagnosed with cancer, caregiving is also shifting to the home setting. With advances in medical care, people are living longer with cancer, and it is being managed more like a chronic illness rather than an acute event needing hospitalization. Couples who face cancer are at risk of depression, anxiety, PTSD, or trauma symptoms, and relationship strain. For LGBTQ couples where one or both partners identify as lesbian, gay, bisexual, transgender, queer, etc., the risk of negative psychosocial outcomes is increased by minority stressors that these couples face and also the accumulation of stress over the lifetime known as allostatic load. Post-traumatic growth, or the positive psychological change that may occur through the struggle with a highly stressful or traumatic event, is associated with positive outcomes such as lower long-term distress, depression, anxiety, and better overall well-being. Post-traumatic growth is actually correlated between partners, such that one partner's post-traumatic growth is positively correlated with the others. So this study would take a strengths-based approach, and it addresses current gaps in the literature by being theoretically grounded, including LGBTQ individuals who have historically been excluded from research, focusing on the dyad, utilizing multiple methods to improve data validity, and addressing current trends in cancer rates and recognition of diverse couples. Next slide, please. So for the first part of my study, I'm conducting online interviews with 54 couples who are facing cancer. Half of that sample is non-LGBTQ couples, and half of the sample are couples who identify as LGBTQ. The surveys are administered through REDCap, and they include 6 validated instruments measuring trauma and loss, post-traumatic growth, depression and anxiety, dyadic coping, couple satisfaction, and positive and negative quality of the relationship. And then for the second part of my study, a smaller subsample of participants who complete the survey are invited to participate in the couples interview. So the goal was for 16 total couples, 8 LGBTQ couples and 8 non-LGBTQ couples. The semi-structured interview occurs via Zoom and lasts about 45 minutes. And I ask couples about how they cope together with cancer and any prior life experiences that may have better prepared them for dealing with cancer. So the online surveys will be analyzed using SPSS for descriptive statistics, and I'll be using HLM, or hierarchical linear modeling software, to run an actor-partner model of the level 1 variables, which means the individual variables, and then a regression model of the level 2 variables, or the couple variables, will be conducted, as well as sensitivity analyses to see if length of relationship, stage of cancer, time since diagnosis, et cetera, are covariates in the relationship between trauma and loss, post-traumatic growth, and well-being. To analyze the interviews, I'm using an interpretive descriptive approach. So it's a kind of an iterative process with constant comparison, where I used 5 a priori codes developed from the post-traumatic growth domains. And I'll be developing a code book with 10 to 15 codes. I have a second coder who will also code 10% of my data for purposes of calculating inter-rater reliability. Next slide, please. So to integrate the qualitative and quantitative data and make it truly a mixed methods study, I'm using a joint display matrix. More specifically, it's called the pillar method, which entails a process of listing, matching, checking, and pillar building. Sorry, my dog just turned off all my stuff. Where the quantitative constructs are placed beside the qualitative categories to see what new patterns emerge. So for example, the scores are next to the categories for quantitative, and then on the right side, the qualitative categories are set beside them to see if there's any connections. Next slide. So, so far, I have 30 non-LGBTQ couples who've completed all the surveys, and 12 of these couples also completed the semi-structured interviews. Up to date, 18 LGBTQ couples have completed the surveys, and 9 have completed the interviews, with 2 additional interviews scheduled. We've reduced the sample size to be 20 LGBTQ couples due to difficulty recruiting, so I'm hoping for 2 additional couples. I've learned some difficult and time-consuming lessons about online recruitment, and currently have a manuscript under review detailing some of the issues that I've encountered. I'm not sure where this research will lead me, but I see endless possibilities to improve psychosocial outcomes for a diverse population of couples. I can eventually see this maybe being translated to a strength-based dyadic intervention. And I wanted to thank my dissertation chair, Lee Ellington, and my committee members, Kathy Mooney, Kathy Supiano, Brian Bockham, and Kristen Cloyes. Thank you.
Thank you, Sarah. We can now open up for questions. I actually had a question. The LGBTQ couples, you had said that at least one person in the dyad was LGBT. Did you have a preference for it? Were you hoping to recruit LGBTQ folks who they were the one with the cancer diagnosis, or do your hypotheses not really matter which one in the dyad is experiencing the diagnosis?
Good question. It didn't really matter in my hypotheses which person had cancer. I will say the vast majority of my sample, both individuals in the LGBTQ couples identify as LGBTQ. I think I have maybe one couple where one person does and one person doesn't identify. But yeah, it didn't matter to me who had cancer as long as they both identified as one of them in the couple identified as LGBTQ.
Thank you.
Sarah, really interesting study. I was wondering if you could tell us more. I'm curious what recruitment challenges you've run into.
Sure, I'll be happy to. Just give me 1 second while I pull something out of my dog's mouth. Okay. So with online recruitment, I had to learn the hard way about bots and also people who misrepresent themselves online. So within maybe I have to go back and look, but within 24 hours of online recruitment, I had hundreds of responses to the interest in survey questionnaire through REDCap. And at first I was super excited and I thought man, I'm gonna get this dissertation done really fast and this is gonna be awesome. And then I started looking more closely at the names and the emails that they were entering into the survey and the timing of it, and began to see some really odd patterns. And so I started digging into the literature some more and basically discovered that pretty much, so the first 600 couples who said they were interested in the study were all either bots or people misrepresenting themselves. So I had to hand sort through every couple to make sure I was including the people who were real, and it was just a very time-consuming process. Banjo, stop.
So Sarah, related to that, where did you advertise this and how did it get the attention of some sort of bot that was autofilling?
Yeah, so I think where I went wrong is I put it out in every avenue, every social media outlet. And I did say, couples will receive compensation for completing the surveys. And I think maybe I should have started out with a smaller net, but I was so worried about getting the sample size that I just threw it out everywhere. And I think most of the stuff I think was through Facebook where people were misrepresenting themselves. I've had a lot of success through snowball sampling lately. So that's kind of where I'm leaning.
All right, I think we have time for one short question if somebody has it.
Can I make a very quick plug?
Yeah.
I still need 2 more couples. So if you know of anybody who'd be interested in participating or have any networks that you think would be a good place to post, please let me know. These would be 2 LGBTQ couples where one or both people are experiencing cancer, 18 and older. Thank you.
Awesome, thank you. All right, so next up we have Sarah Neller, also from nursing.
All right. Thanks so much for joining me today for my presentation on the 1U4U Caregiving Initiative. I am Sarah Neller. I'm a PhD candidate in the College of Nursing, and I'm presenting on behalf of this larger team. Next slide. So for some background, family caregivers are unpaid family members who provide care to an individual who has an acute or chronic condition and needs assistance to manage a variety of tasks, including activities of daily living, community mobility and access, and health management. It's estimated there are 44 million caregivers in the US. Providing complex care, juggling multiple demands, economic pressures, and emotional burden can result in major health impacts for caregivers. Family caregiver research is typically fragmented and siloed by caregiver relationship to the recipient, so like a spouse or parent or child, or by health condition or disease process. The purpose of the 1U4U caregiving study was to utilize community-engaged research practices through focus groups to uncover the similarities and differences of caregivers experiences across caregiving relationship and health condition to inform ways that research may be applied across different caregiving groups. So this presentation aims to present the in-progress findings from the qualitative analysis of the focus group interviews. Next slide. So I am just one member of this amazing team. You'll see here the broader project team at the top, which includes many who are in attendance now and those who submitted the proposal and received the funding for this project. And then at the bottom, I've included and listed the qualitative analysis team. Next slide. So this project received 1U4U funding, and we partnered with the CCTS Community Collaboration and Engagement Team, who conducted 3 online focus groups in the fall of 2020. We're currently in the process of conducting a thematic analysis. Next slide. Our sample comprised 26 caregivers who had a variety of caregiving experiences across relationship and conditions or disease processes, and were a diverse and well-educated group. The majority identified as female. The mean age was close to 50 years old, and just over half were white. In our sample, the caregiving tenure spanned from 5 months to 22 years. 100% of the caregivers reported assisting with medical management, including helping the care recipient go to appointments, taking medications, or following a provider's instruction. And 27% were providing care for more than one person with a long-term illness, injury, disability, or other condition. Next slide. So emerging patterns from the focus groups include caregivers describing the tasks they provide for the care recipient, such as ADLs or decision-making, as well as their needs, emotions, and complex experiences of caregiving. Next slide. So caregivers talked about their needs, which included respite, help and support, and understanding and recognition. Respite, or the need for a break and time away, was repeatedly mentioned by caregivers, but it needs to be under the right circumstances, as illustrated in this quote by a son caring for his mother. Totally worry about, when you're not around the person that you're caring for, that she is getting the right care, they are getting the right care. And is anybody else competent enough to care for the person the way I care for them? And of course, the answer is no, because they couldn't possibly be as good as, give them the care, because I know everything. So it stresses me out. The need for help and support included physical assistance and financial resources. One participant said, "My parents still live on their own, still have their own money to sustain their bills and the house and everything, but the care for them takes away from my job. And so I had FMLA, which when I'm doing that and it's taken away from my pay, then I'm sure it hurt to pay my bills." And the need for understanding and recognition involved the need for others, including providers, to understand the strains of caregiving. One mother caring for her son said, "The other thing that's really struck me," which another participant has said, was the disbelief. "I've had people say to me, 'Oh, he's quite high functioning,' and they've been with him for all of 10 minutes. And so they really do not get it whatsoever, because he covers it extraordinarily well. So, yeah, it's disbelief." Next slide. So caregivers also expressed emotions such as worry, guilt, feeling overwhelmed, and ongoing grief, as demonstrated in this quote. "I couldn't say there was much that was rewarding about it, because there's a deep grieving still going on, because he's still here, but he's not who he was." Simultaneously, they express satisfaction and gratitude in their role. For some, their relationship with the care recipient had become closer. For others, they received satisfaction watching the care recipient achieve their goals. One mother caring for a son with a spinal cord injury said, "The most rewarding part of being a caregiver is watching him grow, watching him succeed and be able to accomplish goals that he set for himself and that have been set for him." These emotions were often felt concurrently, which was evident in these quotes exhibiting the juxtaposition of the positive and negative emotions, such as, "I feel like the scale kind of tips both ways. There's a lot of reward out of doing this, but there's a lot of strain on my shoulders and on my life and on my marriage and even with my children." And also, So you grieve what you do not have and what you don't have anymore, but you're thankful you still have her. Next slide. Our next steps in the initiative include finishing the analysis, submitting the manuscript for publication, which will include clinical recommendations for providers and policy implications such as support for the National Family Caregiver Support Program and workplace benefits for caregivers. The goal is to transform the way family caregivers are included in and supported by traditional healthcare practices. Finally, we plan to form a caregiver stakeholder board to engage experienced caregivers who will inform future research at the U. Thanks so much.
Thank you, Sarah. The floor is open to questions.
I have a question. It sounded like the project was meant to understand both the similarities and maybe the dissimilarities across chronic illness conditions. Can you speak to a little bit, maybe what your findings show on that dimension?
Specifically related to those that were dissimilar?
Yeah, because
Yeah.
this sounds like the similarities. So I'm curious about whether there were dissimilarities across conditions.
For sure. Very often in the focus groups, somebody would tag on to what another participant had said and then say, but my experience is different because, and they would fill in the blank. So often it was, my experience is different because with you might not can partner with your care recipient, but I can partner in decision making with my care recipient because their memory is still intact. A lot of their differences related to struggles specifically relating to the disease process or those caregiver tasks of decision making, and also with ADLs, with supervision, with transportation. But we found more similarities with their emotions and their need for support. Great question. Thank you.
I have a question, Sarah.
Yeah.
Great job. In addition to the policy implications that you'd be writing about, do you see any avenues of like engaging directly with either politicians or other stakeholders in the policy arena who could maybe get this moved forward?
I think that would be an amazing opportunity. Several of the focus group participants mentioned that in other states, caregivers are able to be paid, and how like states like California are supporting caregivers more than Utah is. And I think that it would be a great opportunity for us to engage legislators and ask them about how the state of Utah can better support caregivers as a whole. Thanks.
All right, well, if we don't have any more questions, thank you, Sarah. We can move on. Next up, we have Kelly Mansfield, also from nursing.
Hi, everyone. I'm really excited to be here. Over the past year, I've been working with the SNAZI team headed by Kristen Cloys, studying the social networks and social support of cancer survivors and their support people during the COVID pandemic. Today, I'll be presenting the preliminary data from the qualitative piece of this study. Next slide, please. The overall purpose is to discover how patterns of social support are related to stress and well-being during the pandemic. This portion of the study is nested within AIM 2, which is focused on understanding the perceptions and experiences of caregivers and their support person over time during the pandemic. Next slide. Participants included a cancer survivor and their chosen support person. They had the option to record a 1 to 5 minute long audio diary 3 times within a 10-week period. We asked participants to answer the questions, what is causing you the most stress this week, and who or what is most helpful in managing your stress? Next slide. Currently, there are 58 participants enrolled in the study. 42 of the 58 are completing audio diaries. This analysis includes the first 61 audio diaries, and we anticipate the final sample will include 210 recordings. Next slide. To evaluate the sample, we analyzed the text by group, cancer survivors and support people, using linguistic inquiry and word count software, or LUC. This program provides word counts by percentage, which are associated with psychologically relevant categories using a master dictionary of over 6,400 words. We then determined differences in the language used by cancer survivors and support people by calculating z-scores and p-values on the word count. Once we determined which categories were significant, we created a list of words from those categories that were found in our text. Next, we used NVivo to determine the most frequently used words in the text for both groups, excluding stop words such as and, is, and the. We compared the frequency counts to the words that were found in our text in the significant categories of Luke to determine which words in each category were used the most often. Once we determined the most frequently used words of significance, we pulled concordances on those words in NVivo and inductively analyzed for themes within the text. Next slide. This table contains the demographic information for this sample. Of note, the average relationship is 24.1 years. Our sample contained a variety of relationships, including spouses, partners, children, parents, siblings, and friends. We recruited primarily from young adult cancer groups and through social work support groups at Huntsman Cancer Institute. So our age range contains young adults through older adults, as well as a variety of cancers impacting different age groups. Although we also recruited from a national database, we had difficulty recruiting minority groups, even when narrowing our searches to potential participants within minority populations. Next slide. Luke analyzes 4 overarching linguistic categories. In all of the areas, a high score is close to 100. Based on the informal nature of the audio diaries, we did not anticipate high levels of analytic thinking in these diaries. In all of the categories except authenticity, the support people had significantly higher scores. This indicates that cancer survivors' language was more tentative, anxious, or sad, but also more authentic than those of support people. Next slide, please. We found 8 areas of significance within the Luke categories. The words on these slides are some examples of words in each category. Overall, survivors used more words associated with themselves or I terms, more negative emotions, anger, cognitive processing, and tentative language. Support people tended to use more she, he terms, social language, and were more past focused. Next slide. Based on the word lists from NVivo and Luke, these are the most frequently used words by each group. We use these words to run concordances and determine the themes within the text. Next slide, please. The quotes on these slides are similar to what survivors and caregivers discussed. One thing to note as you review these quotes is the difference in language, with survivors mostly talking about their own health and support people discussing the people around them. Cancer survivors and support people identified several areas of stress. Cancer survivors were most commonly talked about cancer, family, work or school, and COVID. Support people mostly discussed health, which included not just the survivor, but also their own health and that of their families. They also indicated stress related to work or school, COVID, and finances. Exhaustion, pain, and illness were all commonly associated stress outcomes noted by many cancer survivors in the sample, regardless of their treatment status. Next slide. Cancer survivors and support people both indicated that self-care and emotional support were important to them. Overall, support people indicated the people in their lives were very helpful for improving their stress, but often didn't indicate the type of support they provided. They rarely discussed any formal support systems or support groups. Cancer survivors also frequently talked about instrumental support and formal support programs such as social work or therapy. Again, with these quotes, notice how the language of the survivor is focused on themselves, whereas the support person allows themselves time for self-care once everyone else is cared for. Next slide. There are some unique support issues found between partners when the survivor is in treatment. Often the survivor is focused on cancer symptoms as their primary stressor. Similarly, the support person identifies the survivor and their cancer as their greatest stressor, but also discusses how that person is their greatest support as well. Next slide. Overall, we discovered some interesting themes in this preliminary analysis. First, our Luke analysis showed that survivors use more terms associated with themselves, negative emotions, and anger. In other linguistic analysis, these terms are associated with depression. These findings are also supported by the low clout and tone found within the language of the survivor, which is indicative of sadness and anxiety. Next, we found support people use more language that is focused on the survivor and the rest of their network. They report not only the health issues of the survivor, but also their own health and that of the family. Survivors rarely discuss the health of the support person. Finally, some support people reported their own health as a stressor. These health concerns could be caused by caregiver burden, but caregivers rarely reported access to formal support systems, which could help improve that burden. Next slide. This preliminary analysis provides some interesting data about the stress and support of cancer survivors and caregivers during COVID-19. Our next steps are to evaluate all of the diaries of the participants over time and then crosswalk that data with mental health measures, couple satisfaction surveys, and longitudinal support data. And then next slide. I just want to thank my research team who've been instrumental in mentoring and teaching me throughout this process.
Excellent. Thank you, Kelly. Open up to questions now.
Hi, Kelly. Very nice job. I got stuck on one finding you presented, and maybe it's just, it's just a chance finding, but did you say that support persons more often use past tense? Is that right? And do you have any thoughts of why, it's just curious to me why they might have done that versus the cancer survivor? I don't know. I just kind of got stuck on that, and I think it's kind of curious, huh?
No, I mean, I got stuck on that a little too, and I don't think there's enough data yet to really see if that is something that's going to come out in all of the findings. I kind of expected to see that in the survivors more so. And in fact, there was one point in the presentation when I kept saying it was the survivors, and Kristen had to correct me on it because in my mind that made more sense, but that is actually not the way it came across. So I think that's something that we would have to look at more when we have more diaries and see if it remains consistent.
We're also wondering if they're thinking about the past before cancer or the past before COVID.
For COVID. Mm-hmm.
A nice talk. I was struck by the comment I believe you made that cancer survivors rarely talked about the health of the caregiver. And I'm wondering if there's any kind of reciprocal mirror to that from the caregiver side. Like they rarely talked about their own health, or they didn't, or they talked about the not being recognized in their own needs. I don't know if there's any other side of that finding.
So mostly they talked about if the survivor was in treatment, then that was everyone's focus. But our sample had people that their cancer diagnosis had to be in the last 5 years. So when you get to that point where people are shifting out of treatment, then you started to hear a little bit more from the survivors about their own health. But since from the caregivers about their own health, but the survivors remain still focused on those long-term after effects. They talk a lot about fatigue. They talk a lot about just chronic things that are happening afterwards. So they still remain focused on their own health. And we had even one participant who he said his main stressor that week was his own health as a support person. And the cancer survivor did not acknowledge that at all as her main stressor that week. So
All right, thank you, Kelly. I think it is time to move on. Next, we have Megan Hebden from the nursing department.
Hello, I'm excited to be with all of you today. So I'm Megan Hebden. I'm a 232 postdoctoral fellow in the College of Nursing. And before I start my presentation, I just wanted to acknowledge the funding I'm receiving as a postdoctoral fellow through the National Institute of Nursing Research, my wonderful mentor, Dr. Lee Ellington, and the One U for Caregiving initiative for funding this study. Next slide, please. So family illness has been woven into my life from childhood, and it is what prompted me to become a nurse, where I work primarily in oncology and chronic illness care. During my clinical work and education, I had 3 children, And this is a picture of my daughter who was diagnosed with a rare and serious genetic disease, which includes seizures as a primary manifestation. So my experience is navigating the health system with and for my daughter, while also trying to build my family and my own professional career, have really inspired reflection on what it means to be a caregiver while achieving adulthood milestones or milestones in adulthood. And so that led to my current interest in millennial caregivers. And I love this quote by Rosalind Carter. There are only 4 kinds of people in the world: those who have been caregivers, those who are currently caregivers, and those who will be caregivers, and those who will need a caregiver. So like death and taxes, caregiving is something that it will impact everyone's life eventually. Next slide, please. So why do millennial caregivers matter? Well, they are a highly diverse, growing, and understudied caregiving group. They constitute 1 in 4 caregivers. They are at an important developmental stage of building families and careers, while also spending 24 hours on average providing care. They as a group generationally experience more mental illness and are also more likely to be caring for someone with a mental or emotional health challenge. While most of them are employed, their finances are strained. They contribute their income to caregiving, and generationally, they have been impacted by the recession and now the financial crisis related to the COVID-19 pandemic. Their achievement of financial independence is delayed with milestones such as home ownership and starting retirement savings. Most often, they are caring for a parent or grandparent, so they are contributing to the care of older adults, which is huge when we consider the cost and complexity of care for older adults with chronic illness in our country today. Next slide, please. So because millennial caregivers are understudied, I'm kind of starting at the ground floor with trying to understand their experiences as caregivers. And so what I'll be describing is my preliminary work, which has been framed using the dynamic fit model, which you'll see here on the left. And this model proposes that we all have responses to stress. We have automatic responses that occur in the moment and deliberative that occur more over time. And that we might have default strategies that are low in flexibility and so maybe not as positive and lead to adverse health consequences. And then there can be learned positive responses that result in high flexibility responses and may almost buffer that negative health impact of stress. And so what I'm proposing is mindfulness as an in the moment automatic response to stress for these caregivers, and narrative expression or journaling as an deliberative response to stress for millennial caregivers. And the reason why I kind of focused on stress is because of that larger context of these caregivers. And also the idea that these caregivers cannot do anything time intensive. So they need things that are timely and accessible. So my current study, I have been doing caregiver interviews and kind of 2 types. The first is an in-depth, semi-structured interview to understand the stress experiences and stress management needs of caregivers. And so I had a target of recruiting 15 millennial caregivers, and I was able to reach those recruitment targets. We opened the study in February, like mid-February, and we are already at target. So I was a little surprised. Our recruitment strategy was a national approach using Research Match and also social media advertising. The second type of interview that we're doing is a structured interview using app wireframes for delivery of the stress and emotional regulation intervention, the mindfulness and journaling. And so caregivers look through the wireframes and provide feedback about what they're seeing and whether something is intuitive or they don't understand what they're supposed to do. And then in addition to that, we have also collected red cap surveys from 43 millennial caregivers. These surveys primarily include open-ended response questions focused on stress and stress management needs. So next slide, please. So I wanted to talk about the preliminary findings. So I have my final interview for the semi-structured interview tomorrow. So we are still kind of in the beginning phases of looking at our data. But with the wireframe interviews, we plan to use a content analysis approach to analyze the data And then with the in-depth semi-structured interviews, we're going to triangulate those with the survey responses, and we'll be using thematic analysis to analyze those. But these are some general themes. I took notes and categorized things as I was doing the analysis, and these are some general themes that have arisen. For the app, caregivers described wanting both something to help manage their stress, but also to measure their stress. So when they're doing like a mindfulness exercise or a journaling activity, they also want to be able to indicate their level of stress. They also described a desire for social connections embedded in the app because, and we'll see down in the caregiver needs, these caregivers feel somewhat isolated because their experience as a caregiver is different than many people in their same cohort who don't have caregiving responsibilities. Caregivers also describe design changes such as color, the use of icons, and like stepped instructions to help make the app more intuitive. And then as far as caregiver needs, in addition to that need for social support and greater understanding of their role as caregivers and connections with other caregivers, they described their financial challenges and the need for information to understand what their rights were as employees or where to receive financial support for their caregiving responsibilities. They also talked about the lack of respite that they have, and that because of where they're at in life with work and with caregiving, that there just is no space or time for them. And then finally, they indicated a desire for a one-stop shop for resources to support their caregiving responsibilities. Next slide, please. So the next steps, of course, will be refining the analysis and doing that full content and thematic analysis of the data. But really one of the main things that has come out, which I almost suspected, was the need for practical caregiver support in addition to the mindfulness and narrative expression intervention. And so what we'll be doing next is developing what we're calling a caregiver toolbox that will include practical caregiver support needs, but those will be informed by millennial caregivers because the goal is that all of this work will be tailored to caregivers and will address their specific needs. And then we'll move along this continuum to a just-in-time adaptive intervention to understand how things work, who they're working for, and when they need specific interventions. And really, kind of this is my large research trajectory and plan is to develop interventions that improve millennial caregiver well-being. So that's all I have.
Thank you, Megan. The floor is open to questions now.
Megan, I didn't catch what was the average age of the millennials caregivers?
Millennial caregivers are born between 1981 and 1996, or I mean, some people will even frame it between 1980 and 2000. So it really depends on the source for who decides. But in this study, I was using the Pew Research kind of window for that. And so that is 1981 to 1996. But I would say with the caregivers that I interviewed, they were mostly in their late 20s and early 30s. And I had a few on either end of the spectrum. So, great question.
Megan, do you have a sense from these interviews of what types of interventions or what types of skills or tools that would initially be proposed for your toolbox?
Yeah, so really, I think there are three main areas. The first one is financial support and employment issues. And so providing information regarding like paid leave and like where can they find even financial support for their caregiving activities. Like some of the area agencies on aging provide some like, you know, short-term support for things like rent. And so giving people those kinds of resources. The other thing that came up a lot was how to communicate with the healthcare team so that their needs as a caregiver are met. And so, you know, I haven't I have a lot to think about there, but like maybe providing them like go to these appointments with these 3 questions, or, you know, maybe have like take notes and go with a plan for your visit with the care recipient. And then the last one really was how to connect with other caregivers. So it does kind of feed into that social support thing. But my most recent in-depth interview was with a caregiver, and she volunteered for the study because she was so excited that there was somebody doing work on millennial caregivers, because she had felt so alone. And so I do think it can be somewhat isolating. And so really helping caregivers tap into support resources in whatever way they can, whether it's virtually or in person, it would be another focus. Great question.
Thanks.
All right, thank you, Megan.
Yeah.
It's time for us to move on to our last presentation from Sarah Wazinski, also in the nursing department.
Hi, everyone. Thank you. I'm excited to share a little bit of the preliminary findings from my own dissertation research. Next slide, please. I just want to say a huge thank you to my dissertation committee, who supported me in the writing of an F31, which was funded by NINR, and which is supporting this research. Their insights and expertise have been just so pivotal and important in this and getting this going. Give you a little bit of background. Nearly 16,000 children are diagnosed with cancer every year. And cancer treatments, as many of you have touched upon, it becomes kind of a chronic illness. These kids can have heart and kidney dysfunction, fertility problems, learning disabilities, all related to their treatment. And often the focus of parents and family members turn towards the child who is sick. And this often, leaves parents are taxed and maybe not always able to care for siblings in the ways that they always have. Next slide. Siblings of children with cancer exhibit signs of distress, and this has been shown in some recent systematic reviews. Kids can show poor school performance. They can have somatic complaints, so things like stomach aches, headaches, or physical ailments, signs of anxiety and depression, post-traumatic stress symptoms, and behavioral problems. And what's really troubling about all of this is that siblings report not wanting to talk to their parents about these issues because they know that they're already taxed and stressed. Next slide. So for the theoretical framework of my study, looking at the stress buffering hypothesis of social support and wanting to know how the social support that these kids might be receiving can impact the relationship to their psychosocial distress and maybe prevent against some of the more troubling symptoms that they might encounter. Next slide. As a research question, initially started out looking at how do siblings use social support within their networks, and how might this influence their perceptions of social support and psychosocial adjustment. And the Pew's research that is out there shows that 95% of teens have access to a smartphone, and this is kids over 13, with 85% of them using some type of social media. And so we thought this may be a good low-cost resource to help provide support if we know what's important to them and how they're accessing it. So we're currently recruiting for this study. Next slide. And we're looking for siblings of kids whose sibling is actively being treated for cancer, who live at least 50% of the time with that sibling between the ages of 12 and 17, and can engage in an interview process with us. Next slide. For the qualitative aim, which I'm going to talk a little bit about here, is for the interviews, we're creating kind of an echo map of their social networks. We're putting them in the center and asking them who the important people are that provide them support. We're asking them what their relationship is to that person, general age, and for specific examples of the types of support that they're receiving from these individuals. And then we're asking them about whether or not they're connecting with this person either online using social media or technology of some sort, or if they're seeing them in person, or both. Next slide. So just some preliminary findings. So far we have 18 enrolled in the study, 8 male and 10 female. And on average, they're reporting the same number of alters or people in their network supporting them. As you can see, the range for males seems to be somewhat smaller, 5 to 8, whereas females have reported anywhere from 3 to 10 people in their network. As far as racial and ethnic diversity, somewhat lacking, and we're still trying to recruit some more minority participants, but we have 3 Latinx, 1 Asian, and the rest are white. As far as the people that are being reported as being in this network, so 17 of our 18 kids have reported mom. And this was a little bit surprising to me. I thought moms might be less frequently. We all know that moms are obviously very important, but moms are also the ones that are having, in the literature, the most important role in the caregiving of the child with cancer. They're the ones traveling to appointments, are not home all the time, and are often the ones spending all the time in the hospital with a sick child too. So that was interesting. Next, 16 of the 18 selected a peer or a friend. Dads were next on the list, with 15 of our 18 participants listing dad. Siblings report that other siblings are really important to them in providing support. And then relatives. So these are grandparents, aunts, uncles, or cousins that they've mentioned. And then to a lesser degree, about 28% of our kids have mentioned a neighbor, a teacher, a therapist, or even a pet as being a support. When we're just starting the qualitative analyses here, and we're going to be taking the examples of the support that they're getting and trying to categorize them into the common types of social support in the literature. One that I think was interesting is when we think about instrumental support, this is often, money, meals, transportation, but these kids want a distraction. They want something that's getting them away, giving them a sense of normalcy, and being a distraction from cancer or some of these distressing things that are going on in the home. And then obviously someone to talk about, someone who understands what they're going through. Next slide. Some other kind of emerging themes is that siblings don't seem to be using social media for support per se. So they're reporting using it as more of a distraction, a way to keep in touch with their friends, but not actually for support in terms of what they're going through with their experience of having a sibling with cancer. We're also asking siblings about how they think that their use of technology or social media has changed, and they're reporting an increase, especially FaceTime and texting in terms of keeping in touch with their parents, and especially moms when the child who has cancer is in the hospital. And siblings really express a desire to spend time with the child who's sick. Being able to spend time with them or be able to see how they're improving over the cancer trajectory gives them a sense of support and comfort in this experience. Next slide. We're also collecting some quantitative measures where we're asking about their perceptions of social support. We're looking at their social media use and trying to understand how their social media use might be influencing their perceptions of support, or the relationship between their perceptions of social support and any behavioral or emotional problems that they might have. Thank you.
Excellent. Thank you, Sarah. The floor is open for questions.
I have a question. I thought that was really impressive study. It's interesting in some of the work looking at how friends are used for individuals who are sick. It's very rare, but it was interesting here that the friends were used as social support. And I don't know if you have any thoughts about why they're so much more frequent here than if for example, if you'd asked maybe the people, the kids with cancer, they might not have said that the friends were the support person. So any ideas on why maybe it's so prominent here?
I think that having 1 or 2 close friends that seem to understand and just will reach out to them and say, hey, are you doing okay? Or being able to talk, but they often don't say that they're not talking about this all the time. They just want somebody that knows their situation, but then they're still sharing like this normal kind of teen relationship or friendship with the person that they're mentioning.
Mm-hmm.
And I'm intrigued by the findings so far that social media is more for distraction than for support. And I wonder if that correlates with other studies in this population in other settings, if you have any idea of that.
I really thought that I would find more support, and that my early research work when I started the PhD program was in diabetes, and they have just such huge online social supports and are really integrated in that. Part of it I think is developmental. And then also a lot of these kids have mentioned not wanting to know about cancer. So I think they're not necessarily leveraging social media in that way to try and find support. It's more to maintain sort of a sense of normalcy and just maintain general connections with their peers.
And are you, I didn't hear you say this, but are you looking at all the affected siblings or the affected children with cancer?
No, we're not. This is just the siblings. But we are collecting some just like family, like what is the sort of makeup of the family? So is it a blended family? Is it a single parent? And then also asking just about what the type of cancer is, so we know whether it's more of a high risk, a long term, so that may play into sort of the trajectory or some of the things that they're experiencing.
Sarah, this is Shireen. Great job. I have just a question about the sibling part. Do you have any sense of, because your population is from, did you say 12 to 17?
Yep.
So the siblings, do you have a sense that they're older siblings, like older than 17?
It's a mix. You mean the sibling with cancer?
The ones who are the support, that they identified as the support?
Interestingly, it is a mix. Some kids have mentioned that it's fun to play with their younger siblings because they're sort of like more oblivious and they can just, have normal, fun playtime with them. But then they're also mentioning older siblings as being somebody that they can talk to about what it's like and some of the more stressful elements of their experience.
Thanks, great study.
Thank you.
All right. We did an excellent job with time management today. Excellent work, everybody. I'm very impressed. You didn't even need a timer. You were all very good. So it is my understanding that the judges will be announcing the best presentation in the next day or so. So keep an eye out for that. Everybody, you did so amazing. I hope this was beneficial to y'all as much as it was enjoyable just to see everybody's faces and to see real people behind the emails. So thank you so much. That's all I have. I don't know if Cindy or Austin had anything they needed to add, but awesome job, everybody.
Great job, and thanks, Jenna, for being the MC here. Really interesting work and great project. So thank you all.
Thank you.
Thank you.
Thank you.
Thank you.